Thank you. Welcome, everyone. I'll just do a brief introduction. Dr. Castellani is a professor of pathology in the Division of Neuropathology at Northwestern University Feinberg School of Medicine. Dr. Castellani received his MD from Wayne State University. He completed anatomic pathology residency at Wayne State University and a neuropathology fellowship at Case Western Reserve University. He was formerly a tenured professor at the University of Maryland, Baltimore School of Medicine, and has directed neuropathology divisions at the University of Maryland Medical Center, Western Michigan University, Homer Stryker MD School of Medicine, and West Virginia University, before accepting a position as professor of pathology at Northwestern University Feinberg School of Medicine in 2021. His research group has published in the New England Journal of Medicine, Nature Medicine, and JNEN, among other peer-reviewed journals on the topic that he's going to discuss today, and has been quoted on this topic as well in the New York Times and other media outlets. We're looking forward to your presentation.
Thank you very much. The title is Anti-Amyloid Beta Immunotherapy-Related Vasculitis. I have no conflicts. I include a few opinions toward the end mainly, and these are just my opinions. I don't speak for an institution, an organization, or for that matter, even a department. So the topics we're going to cover are, I'll make a few comments on cerebral amyloid angiopathy, which is an emerging issue. Well, it's been an issue throughout, but it's becoming more and more important as these agents are coming on board. We'll talk a little bit about post-treatment neuropathology, what we know, and a little bit about amyloid-related imaging abnormalities and what the possible pathological substrates are. The initial description or initial identification of CAA is generally accredited to Oppenheim, where he noted metachromasia in the vasculature. Oscar Fischer published in more detail and included very nice illustrations actually of probably what we would call cerebral amyloid angiopathy today. You can see the picture there from reprinted from a 1910 publication showing what looks like capillary CAA. 1927, it was found to be congophilic, not just the plaques, but the vasculature. So congophilic angiopathy, so to speak, has been around for about 100 years. This is an interesting publication. It's a dissertation from Gellerstadt from 1933, and I actually purchased a copy. And it's interesting to see what the knowledge base and the details of what was known even 100 years ago. Showing a nice picture of our gyrophilic cerebral amyloid angiopathy, as well as a little bit of a dysphoric pattern. There's a nice review published about 20 years ago now by Dr. Attems, of course, a prolific scholar and editor-in-chief of ACTA, showing a sort of a 6-stage progression from moderate, severe with double barreling, and severe with so-called dysphoric changes, two terms that you probably don't hear outside of the various lions' dens out there of neuropathology. But it's interesting that we see these changes, and there's really no biomarker for such changes. It's something that pathologists only see, and it's a sort of an indication of the heterogeneity of the disease process. A number of vessels are affected. Apparently, in the literature, they may vary as a function of ApoE allele and so forth. But arteries, arterioles, capillaries, venules, and veins have all been described as accumulating amyloid and in varying amounts. Just a brief comment about this dysphoric pattern, just because it's interesting, and again, it's not something that comes out on imaging or in any other way other than pathology. This was actually a case at our center of a logopenic variant of primary progressive aphasia. Happened to be 3-3 homozygote at ApoE. And you can see a fairly prominent dysphoric pattern. And we'll go in higher mag to the right with the tau stain. You can see there's an abundance of tau that sort of outstrips the amount of parenchymal A beta deposits, which again just shows that these conditions are heterogeneous in terms of their anatomic morphology. You can see there's a neuritic accumulation around the blood vessels there. This just highlight one case report here of the so-called dysphoric pattern mimicking Creutzfeldt-Jakob disease by the group in the Netherlands. Yeah, just an interesting pattern that, again, is just, you know, would this show up on a PET scan? Who knows? You know, is it associated with cognitive deterioration? I think that that's likely. But again, it's something that's outside of the general spectrum or the general scope of plaques and tangles. And this is just an example of a case that we saw here on an autopsy service where basically every capillary in the cerebral cortex was labeled by amyloid beta. And this was an 84-year-old individual with dementia, had no tau deposits or virtually no tau deposits at all in the cerebral cortex, but nonetheless had dementia and had abundant amyloid beta in the capillary. So again, it raises interesting points about the vasculature and a potential association with cognitive decline, which in the setting of CAA is not that straightforward. Tal and colleagues popularized the notion of type 1 versus type 2. Again, a couple decades ago, type 1 basically has capillary involvement and an association with ApoE4. Type 2 lacks capillary involvement as association with ApoE2. And now these are associations. These are arrived at by odds ratios and so forth. It falls short of being diagnostic, but having an ApoE genotype and a particular pattern. These are I would look at these as overall tendencies, but it is interesting that susceptibility alleles at both pro and against Alzheimer's disease both relate to or both have a risk of cerebral amyloid angiopathy. The Rush group thought that capillary CAA really did not drive the cognitive outcomes in their series. So again, some complexity there in terms of capillary involvement. Whereas at Thames and Yellinger, it's a slightly different question they're asking, but in their hands, it was only the capillary CAA that correlated with Alzheimer's disease pathology. So again, there's some nuance here and some interesting findings. And again, just bring up these details because we now have agents that are targeting A beta, including the parenchyma and including the blood vessel walls, as we'll see. So, you know, a detailed, at least understanding or background in cerebral amyloid angiopathy, I think is going to be more and more important going forward. This is just an incidental case in a bank that I work with where they do A beta stains in anybody age 50 and older. This happened to be a 50-year-old with fairly abundant cerebral amyloid angiopathy, probably mainly in arteries and arterioles. You know, again, incidental at age 50, a very uncommon pattern, but again, these things are out there, so it's a bit idiosyncratic. So what is the prevalence of cerebral amyloid angiopathy in Alzheimer's disease? According to one systematic review, it was roughly 48% if you base that on pathology. Again, we're talking about moderate to severe cerebral amyloid angiopathy. 22% based on lobar microbleeds, which in the proper age group is a very reasonable surrogate for moderate to severe or frankly severe cerebral amyloid angiopathy, which means that there's a number of individuals with moderate severe disease that will not come out on MRI scans. So something to keep in mind. It's an idiosyncratic condition that's going to be out there. And so if we're administering anti-amyloid agents at scale in the population, you're going to be administering it to some number of individuals with cerebral amyloid angiopathy who would not come out as apparent on MRI scans. What about any cerebral amyloid angiopathy? I think the neuropathologists here would kind of agree that if you look hard enough, you can find it in just about any Alzheimer's disease brain, although again, it's a spectrum. So in my opinion, I wouldn't necessarily trivialize it and say, well, they all have it. It just goes along with the disease in a uniform way. It's really not that straightforward. Some cases have very little to none, and some have an abundance, and some have these dysphoric patterns and so forth and microbleeds. So there's a spectrum within the setting of Alzheimer's disease, but certainly very common. This is a busy slide. I just wanted to bring up the issue of ApoE genotype. It's known that E4 and E2 are both risks for cerebral amyloid angiopathy and risk for CAA-related hemorrhage, but because epsilon 3 is the most common allele in the population, you do have a lot of individuals who have severe cerebral amyloid angiopathy in the setting of Alzheimer's disease, and have the homozygous E3 genotype. So basically, imaging can only get you so far. ApoE genotyping can only get you so far. There are going to be cases of severe cerebral amyloid angiopathy that are going to appear in large case series, that, again, cannot be predicted on the basis of genetic risk or on the basis of an MRI scan. The so-called Boston criteria is a useful sort of operational, paradigm for identifying or diagnosing cerebral amyloid angiopathy. Definite disease is only found by postmortem examination. Probably not comforting to the patients that's the case, but with clinical data, with pathologic tissue and or MRI scan, you can only get to probable. So the major shortfall of the clinical criteria are, again, a step down in sensitivity and the possibility that you will run into cerebral amyloid angiopathy cases, irrespective of genotype, irrespective of imaging findings. So just something to keep in mind. I had a chance to collaborate with David Gate and Lynn Van Olst, who did incredible work on a series of post-treatment cases. We had access to the case we saw at our institution, as well as case material from the University of Southampton group, who've done pioneering work in this area. And it was through that collaboration that I was able to look at a few slides from this initial active immunization trial. I never got past phase 1, but they did treat patients, and you'll recall, if you were around back then, that there was an issue with encephalitis or meningoencephalitis in some 6%. The trial was stopped, but nevertheless, patients were followed over time. And so we had the chance to see whether, what the effects were long-term with, at least in this case, the active vaccine. And I don't have the clinical information on any of these. I just have slides, but I'll show you what I saw in a couple of these slides. This is a amyloid beta immunostain of the cerebral cortex. Someone who received the active vaccine and was autopsied some years later. Completely negative. This is a tau stain of the same part of the brain, showing an abundance of NFTs, threads, etc. So the neurofibrillary pathology seems to be ongoing. At least that was a conclusion. But incidentally, the CD3 stain years down the road, where it did not reveal any significant T lymphocytic inflammation, so it didn't seem like that persisted over time, but certainly it looked like there's some clearance. Here's another case, A beta IHC, flat negative, tau IHC in the same brain region, showing a brain riddled with tau. So certainly amyloid clearing. I think, it's always sort of tricky to infer something like clearing in an autopsy specimen. How do you know a dynamic process like that? But I think we can conclude that based on what we know about Alzheimer's pathology. This is just a pattern that you don't encounter in nature, to see no amyloid and this much tau. If you thought, well, maybe the stain didn't work, here's another case that showed some persistent A beta immunoreactivity in the cerebral vasculature, very little in the parenchyma, and tau stain showing an abundance of tau in the parenchyma. Another case showing some cerebral amyloid angiopathy, a little bit, and not much in the parenchyma by A beta, and showing an abundance of tau. Still another case that showed an abundance of A beta. So not every patient had the same response. That's what I infer from these, and tau here. So, but a lot of them did. And the conclusions from those trials, from this group, dating back to 2008, where that the patient did progress to terminal end-stage dementia, and some of those patients who did progress had complete clearance of A beta plaques from the brain. And so that's somewhat problematic, I would say. So that I think the agents are interesting in terms of the recent studies showing a modest reduction in the rate of cognitive deterioration. Does not appear to be absolute. In a more recent study, they again noted patients progress from mild moderate to severe dementia, including a number of individuals who had near complete clearance of plaques from the brain, and appeared to do so at roughly the same rate. So interesting findings, and having had a chance to look at the slides, I fully agree with the findings that were published, that there was indeed clearance of amyloid from the brain of these individuals. The impact on cognition is a very complex question. Ed Plowey and colleagues published a case report of aducanumab. Now this is a humanized monoclonal, no longer the active vaccine, showing evidence of clearance of plaques from the brain. There was not much comment or not much discussion of the cerebral vasculature or an effect on the cerebral vasculature in this particular case report. And then around in 2022, this patient, I'll elaborate a little bit. This was a 65-year-old woman who was an attorney for a good part of her life, transitioned to become a psychotherapist, which is interesting, and retired about a year prior to this. She was very, very quote unquote gung ho about the new therapeutics and the new science, and she enrolled in the phase 3 clinical trial of lecanemab. Was in it for a period of years, and the data we got back after the fact suggested that she was on the placebo in that trial. But then in the open label extension phase, then she received treatment, and she received 3 doses over a month, so they're biweekly doses, 3 doses. Looking back at the records, hard to say what the initial impact was. There was some suggestion that there were some word finding issues after the first dose that was not well characterized clinically. It was just reports from family members. A couple days after the 3rd dose, she was out having dinner with her husband, drinking a glass of wine. But that was interesting that the medical records, the patient's husband endorsed a glass of wine. And she developed a sudden onset of confusion and garbled speech that progressed into speech arrest, and became a medical emergency. Presented to the emergency room, and so you have an aphasic patient. They did a CT angiogram, and they thought they saw a distal MCA branch occlusion. Not a large vascular territory lesion. There were some signal changes by CT. This is prior to any medical intervention otherwise, but went through the stroke protocol and ruled in for a candidate for TPA therapy. I should say that the protocols, I don't think, were meant to include patients on anti-A beta immunotherapy. So in a sense, we have a man-made disease process now entering the clinical algorithms for stroke treatment. And I think that was probably somewhat problematic in this case. And so qualified for TPA infusion, was administered TPA. Within about 10 minutes, started convulsing, had to be restrained, had to be placed in a medically induced coma, expired 4 days later. So obviously something went wrong. And of course, during the clinical course, we saw this, which is massive multifocal hemorrhage on MRI scan, and we have a gross brain showing the same thing. This very, very pronounced, lobar pattern of hemorrhages of varying sizes. Microscopically, we saw a very distinct, I call histiocytic vasculitis. So you have histiocytes infiltrating the blood vessel wall, but only those blood vessel walls that contained A beta. Like here, you can see a little bit of A beta that's residual here, and we see histiocytes, including multinucleated histiocytes, And we see some fibrinoid necrosis here. So this is a genuine vasculitis. And you can see the fragmentation of the amyloid beta on the A beta immunohistochemistry. So I think the pathology here is clear. We sort of went into a little bit more detail in a subsequent paper. That the New England Journal was just a correspondence or a letter. And this is just these panels are emphasizing the extent of fibrinoid necrosis in the blood vessel wall. Fairly bland, monomorphic, for the most part, histiocytic infiltrate in the blood vessel wall, but fibrinoid necrosis, so the acute injury to the blood vessel walls. And of course, acute injury is fibrin, and fibrin is a substrate for TPA. So again, in retrospect, it's pretty clear what happened, right? The lecanemab did what it was expected to do, which was cleared amyloid, but in the process, you had this collateral damage to the vasculature that then became a substrate for TPA. TPA administration then resulted in a multifocal hemorrhage and the death of the patient. Again, a panel showing amyloid beta immunostains, showing vessels with varying degrees of fragmentation, digestion of A beta. Very, very powerful agents that we're dealing with here. Again, and it's also important to keep in mind, this is after just 3 doses. So this is really in the subacute phase of treatment. And it overlaps with that phase where you see the imaging abnormalities. So I think what we're looking at, and to some extent, is the pathologic substrate for these imaging abnormalities. But even after just 3 doses, we could see some evidence of clearance of A beta. If you look on the top panels are middle frontal cortex, the lower panels are superior temporal, showing a marked difference. Now, why it would be superior temporal over frontal, one doesn't know, and you don't know if the person had continued on therapy, for a number of months. Would then the middle frontal start looking like the superior temporal? I think is entirely possible, but I think that it's evident that the agents are doing what they're intended to do, which is clear amyloid beta. And again, this is just n equals 1, but I think it's a very informative case. It looks like there's a step down in tau as well in the same brain region, same slides, same brain regions. It's not a super precise quantitative measurement, but it looks like there's a step down in tau, which raises interesting questions. Is there a level of basically promiscuity of the microglial response? Is this process shutting down tau in some fashion? But again, very interesting, I thought. If you look carefully, you could see that there's evidence of plaque phagocytosis. Now, those neuropathologists are used to seeing microglia within and around senile plaques, but not to this degree, and not to this level of chewing up and fragmentation of the amyloid plaque cores. So in addition to the vascular changes, we certainly have plaque phagocytosis. And you can see the A beta stain. This is not your typical plaque. It's basically the amyloid beta transitioning to microglial cells, CD163 there. I should also point out our particular patient would have qualified for quote unquote high burden Alzheimer's disease neuropathologic change, and yet was living independently and doing fairly well apparently. So in addition to everything else, this person had a considerable degree of resilience, and which is another interesting topic. So around the same time, same circumstances, an older woman was treated with lecanemab, and after 3 doses, again, the same time frame, developed, I guess these are more on the lines of microbleeds. This person was not given intravenous thrombolytic agent, but nevertheless did poorly and died. And you can see the hemorrhages here. And this was published in detail in Nature Communications that I would refer you to for more details. But one thing I would point out is that the vascular pathology that they depicted in this case was basically identical to the vascular pathology that we saw in our case. So it looks like, again, histiocytic involvement of cerebral amyloid angiopathy, along with destruction of the blood vessel wall and fibrinoid necrosis. Let's see here. Okay. We saw a biopsy case of by a colleague, Dr. Jamshidi. It was assigned to him actually, but this came, I think, within months after we saw our lecanemab treated case, and it was striking how similar the pathology was of this cerebral beta amyloid related angiitis. Now, this is idiopathic endogenous CAA angiitis with multinucleated granulomatous inflammation, very similar to the case that we saw. Although there seemed to be marginal differences in the sense that our case was a little bit more necrotizing, and the CAA related endogenous angiitis case had a few more mononuclear lymphocytic infiltrates. We did not see many lymphocytes at all in our case. It seemed to be primarily microglia / macrophage / histiocytic immune response. But interesting that I think we're looking at, immune response to amyloid, one endogenous and one exogenous. There's a very nice publication on this issue some 20 years ago by Scolding and colleagues that demonstrates pathology that, again, is very similar to what we saw in our treated cases. And it came up during the course of our publication, particularly in the New England Journal, that was our case coincidental CAA related inflammatory disease. I suppose it's difficult to exclude. It would just be a considerable coincidence if that were the case. And again, I don't think they were identical. Ours was very bland, monomorphic histiocytic necrotizing process. These also can be necrotizing, but it didn't seem to be at that degree. But this comes into the discussion. I think there's one paper out of Japan that suggested that the very distinct form of A beta related angiitis has a prevalence of about 1 in 700,000 people. So it's not common at all. And there are probably some of you out there who have seen such cases, but I would be surprised if you've seen any more than anecdotal instances. So it's interesting that if we have the hypothesis that this is immune mediated, one is antibody driven, which is the design of the antibody, treatment driven, the other is endogenous, perhaps a similar pathogenic process. Okay. The issue of amyloid-related imaging abnormalities, I think, first arose in the bepanizumab trials of the 2000s, where some patients, after a period of weeks, developed vasogenic edema, or was said to be vasogenic edema, but there was some discussion of what it really was, and it seemed to come and peak after a period of weeks and then decline and quote unquote clear. So a work group meant to deal with this issue and came up with the acronym ARIA. Has reminds us of something like this. Very pleasant sounding name, but it's really an expression of uncertainty, amyloid related imaging abnormalities. And so the question is, what is the basis for ARIA? What is that? What is that signal change? The initial hypotheses were that there's a transient increase in vascular amyloid, and there was basically clearance of vascular amyloid in the perivascular spaces of the brain, and that there was sort of a drainage backup. So what we're seeing in the blood vessel wall or what we could be seeing in the blood vessel walls are not vasculitis per se, but basically a sort of sludging or drainage backup of histiocytes that are clearing the amyloid beta and getting into the blood vessel wall. I think that's a little bit far-fetched based on the cases that I've seen. That they pointed to a couple of publications in this initial rollout of this acronym to substantiate that finding. One was a case report. Again, this is just a theory. They call it a possibility. Efflux of A beta through the brain through perivascular drainage pathways. And they appointed another paper here by again the Southampton group, who looking at roughly 10 cases of immunized patients and controls, thought there might have been a transient increase in A beta with treatment. And again, the thinking was that is that a substrate for ARIA? Is that a clearance mechanism? Again, I have to say from our case and from the Vanderbilt case, this does not appear to be what's going on. I think it's in string theory, but it does not appear to be what's going on. This is a recent review by an extraordinarily prolific scholar in cerebral amyloid angiopathy, and they spell it out. This is so cerebral amyloid angiopathy is a condition characterized by vascular A beta deposits, and is ARIA the manifestation of direct target for antibody-mediated inflammation? So antibody-mediated targeting of the cerebral vasculature, that's vasculitis by any other name. And so I think that as pathologists, we shouldn't shy away from that term. The question of vasculitis, and I know that for the diagnostic pathologists out there, you see this on a regular basis. You get these inflammatory disease states, and you'd have various vascular infiltration. You might do things like it's the endothelium, plump, or you do an actin stain of the blood vessel wall. Maybe we can see targeting. The question always and forever is, where is the antigen? And oftentimes in CNS vasculitis, or what you think is CNS vasculitis, you really don't know for sure. In this case, we know exactly what the antigen is. It's cerebral amyloid, and these agents are engineered to target that very substance. And you get vascular injury, you get histiocytic inflammation, you get multinuclear histiocytes, you get fibrinoid necrosis of the blood vessel wall. So what I'm trying to say is that if there ever was a vasculitis, this would be it from these couple of cases that we've seen. So I just want to heighten everybody's sensitivity to that possibility. And when you look at sort of the ARIA is kind of presented as this sort of transient evanescent sort of functional, quasi-functional change that clears and so forth. When we infuse these agents and their brain lights up on scans, are we infusing a vasculitis? And is the vasculitis the substrate for that amyloid-related imaging abnormalities? I think it's a legitimate question. And it's not surprising that in some cases it could be self-limited or evanescent, depending on how much you have, how much amyloid beta you have. And these are usually smaller blood vessels, collateral flow and so forth. So it's not surprising that it could come and go, and that either if you stop the antibody or if you continue and the amyloid just gets chewed up and runs its course, that the imaging changes could disappear over time. And again, this is another image of the case that we had. And I should say also, I'm trying hard to get virtual slides over to the AANP. So you don't have to take my word for it. Please don't. You can look at the case yourself and come to your own conclusions. That would be great. So of course I couldn't get it uploaded for technical reasons, but I'm going to send the couple of virtual slides in the mail, and those should be available to the group. But you can see here again, there's multinucleated histiocytes, there's a destruction of the blood vessel wall, fibrinoid necrosis, hemorrhage, etc. So the final point that I would make is the issue of target. Lecanemab is kind of promoted as a drug that targets soluble protofibrils. And they show that by in vitro testing and so forth. And it is said to have a roughly 10-fold increased affinity for soluble protofibrils compared to insoluble. And I don't think that's something that I would dispute. I think that some consideration, though, for the relative amounts of soluble versus insoluble might be worth considering, because the brain in AD is full of insoluble A beta, and insoluble is still a target of these drugs. And so it's really the primary effect that we're seeing, a target on the insoluble and not the soluble. So I think that's another point, that as pathologists, we can see insoluble A beta, we cannot see soluble. And I think it's empirically clear that you see targeting of insoluble. Targeting of the soluble, we kind of have to take on faith, because we can't see it. We can't see it with our own eyes. We can't see it through a barrel of a microscope. So that was, I guess I went through this relatively quickly, but those are just the points that I wanted to make. So it appears that amyloid beta immunotherapy causes a necrotizing vasculitis in patients with cerebral amyloid angiopathy. It appears to target insoluble A beta. In fact, one could wonder whether these drugs are actually, administration of these drugs could be sort of a diagnostic test for the presence and severity of cerebral amyloid angiopathy. If you infuse the drug, the brain lights up, you have cerebral amyloid angiopathy. If you don't, you don't. And there's certainly a robust microglial reaction, and possibly also myeloid-derived macrophages. We're trying to work that out. And this microglial response may have something to do with what's been noted as brain shrinkage over time by MRI scan. Patients on these drugs apparently have a statistically significant decrease in brain volume compared to controls. Is that because the microglia are carving out the amyloid, or are they carving out the amyloid with plus other things? Unclear. So, and yes, necrotizing vasculitis likely comprises substrate for ARIA in most cases. And again, this is based on a very small number. This is hypothetical, but I think it's a reasonable hypothesis. And then the notion of perivascular clearance and sludging and so forth, I think that was always a theory that was never confirmed, and it's certainly that theory is inapplicable to the cases that I've seen. So I think we've sort of might do well to set this notion of perivascular clearance aside. We actually had questions from New England Journal editors. They pressed us, "Are you sure it's vascular? Are you sure it's vascular? It might be perivascular," because that idea is out there. And it seems to be there's an avoidance of the term vasculitis out there for one reason or another. I suppose it's a quote unquote inflammatory term, but it's there, at least in the case that we've seen. And in terms of implications for postmortem neuropathology, these cases will only continue to accumulate over time. You will have cases, the subacute phase that we saw are going to be very unusual, obviously. You'll probably get more chronic cases, but I think it'll be important for the various ADRCs and others across the country and across the world to do some detailed analyses of the proteinopathy burden, microglial responses, vascular disease, neurovascular changes, and so forth. So that's all I have, and I'll be happy to open the rounds up to any questions or comments that anyone has. And I thought I saw something pop up from Dr. Del Biggio. So I'm going to end it there.
Thank you so much. I'm just going to encourage people, right, that we're moving to the Q&A session. You may submit the questions via the chat box, or also you could also unmute to ask a question. Looks like we have plenty of time for conversations. When submitting it via the chat box, make sure that the message is to everyone so that both presenters and attendees can see the question. Once you've asked questions, if you unmute, please remute to avoid background noise. And you can go ahead and address Dr. Del Biggio's question.
Should I get off of share screen mode here?
That should be possible.
Yeah. So, I had a recent case. This is Dr. Del Biggio. Look at severe amyloid angiopathy, ischemic stroke by imaging at autopsy, intense inflammation, lymphocyte giant cells. Which came first, inflammation or ischemic damage? Yeah, well, but I guess without knowing the details, I guess I would vote for the inflammation. But that depends on the nuance of what you're seeing there under the microscope and the clinical progression of the case. Um, and I assume this was not a treated patient. Is that right, Dr. Del Biggio?
Yeah, that's correct, untreated. So
Yeah.
it's just weird that there was zero inflammation anywhere else. And
Yeah. Well, that's another, I mean, so the whole issue of CA related inflammation is another huge, broad topic, irrespective of treatment and how to identify it, how to characterize it, pathologically, how do you grade the severity? And I think there are various efforts out there to try to do so. The case that I mentioned, and probably your case, was probably the more rare phenotype of a fairly pronounced immune response against the amyloid, which you see rarely. I think if you look for just any amount of inflammation, macrophages here and there, you might find various degrees of inflammatory changes. And there are some in the amyloid cascade world who view, and appropriately so, A beta as immunogenic naturally. So everybody with A beta has some degree of immune response to A beta, and I guess it's a matter of degree. So the question is, for patients with lecanemab, where should we usually see the most robust microglial reactions, perivascular, intraparenchymal, around the plaques? So certainly the parenchyma, when they're A beta deposits, and it seems, again, this is preliminary information, but the parenchymal A beta plaques appear to be inciting a microglial response per se. The vascular disease, a CAA-related inflammatory process, may be more myeloid-derived macrophages. So I think anywhere you have a plaque, you'll see an inflammatory response. In our particular case, it looked to be the most robust in the temporal lobe and in the medial temporal lobe, although that could be because the medial temporal lobe plaques, such as the hippocampus and subiculum, are big and juicy and they're easier to see. But it seems to me anywhere in the cortex, you can expect a microglial reaction, and then anywhere. And of course, our case, the vascular inflammatory disease precisely paralleled the presence of cerebral amyloid angiopathy, which has a slightly more posterior distribution. And also in the cerebellum, we found inflammatory changes in the cerebellum as well, but they weren't really that not quite as pronounced as in the cortex.
Maybe also a follow-up question to that. So for any of us who receive a brain from a patient treated with lecanemab or donanemab or something similar, what should we be considering doing or looking for during workup of these patients at autopsy?
Well, I think it's important to, number one, get the case, because I mean that's not a trivial thing. If a patient dies in the hospital, what's the autopsy rate? 5% or something. Patient dies at home, they're going to be referred to the medical examiner's office, and they're not going to take the case. They're not going to post. It's going to be a natural and done. So the challenge will be actually getting the autopsy. So once you get the brain, I think you do what would be kind of what appears logical, which is look at the proteinopathy burden. Do you get a sense that amyloid beta is being cleared? Look at the tau burden. It looks like there's some tau clearance. In fact, that's also been shown by biomarker analyses in these clinical trials. There's also a downstream effect apparently on tau. So I characterize all that. Of course, look at the vasculature. I think that if we see our cases in the subacute phase where there's a pronounced inflammatory response, I would imagine that would be gone once the imaging abnormalities are gone. And so what's left behind? Are the vessels sclerotic? Are they not? Is there microaneurysms developing because of problems with the blood vessel wall? just whatever you think as a pathologist, what would be the best way to characterize this in much detail? And of course, you know, the microglial reaction, microglial response that can, you know, that gets, you know, complex. You know, maybe as time moves on and we, you know, we're getting more into machine learning, image analysis, and so forth, we can do more precise quantitation of the proteinopathy burden, the neuronal counts, the microglial responses, and so forth. But I think the key, or the challenge, the limiting factor is getting the actual autopsy. Our particular case, you know, required a very engaged spouse to pursue the autopsy. I can tell you that, again, if the person had died in hospital, the Cook County medical examiners would not have touched it. You know, it's a natural death, done. So that I think getting the case to begin with, I think, is the challenge.
Maybe a quick follow-up to that too. Are you aware of any broad efforts to try to get more donations from these patients?
Yes, well, we're, you know, at our institution, we have an infusion clinic, and so if they're enrolled in our clinical core, well, we will get the autopsy. So that's sort of built in. And I'm sure other institutions are doing the same thing. There's a keen interest in these cases. So I think my guess is you'll slowly see the appearance of more and more, and then we can interrogate some of these initial findings in more and more detail and find out, is ARIA really a vasculitis, or is it more complicated than that? Is there something else going on that's contributing to that? Yeah. And there's a question that says your myeloid macrophages may be translated to the so-called border-associated macrophages that include perivascular meningeal, which can be distinguished from parenchymal. These two populations can be distinct. Yeah, yes, and that gets into microglial biology, and you know, I only know enough to be dangerous in this space. So, but but it is an area that of interest, and again, we have some preliminary information that suggests that the problem in the vasculature was not microglia, but was rather myeloid-derived macrophages, based on immunolabeling.
Dr. Perrin posted a question. Thank you very much for your talk. Very nice. Not really a question, but I think it is important to note that there are two kinds of ARIA, ARIA-E and ARIA-H. Also, though I have not yet seen any cases with lecanemab therapy, none of the cases of DIAD I've seen treated with gantenerumab or solanezumab, N-of-4 each, have shown any vasculitis, including a GUNT case with clear evidence of amyloid removal and some ARIA-E, which resulted a few months before death. Consequently, I think it may be premature to ascribe all ARIA to vasculitis. That's Dr.
Yeah,
Perrin.
I mean, I basically agree that it's a premature, but it's a striking finding. So I think it should be taken very seriously. I mean, we have our patient basically was administered 2 drugs that led to her death, one of which was lecanemab. So it should be taken seriously. And the other thing about so ARIA E and H is, you know, what is there really is it really dichotomous? Is it the same process, one resulting, because you can imagine a vasculitis not producing hemorrhage, but or the same vasculitis will produce hemorrhage. So, you know, the ARIA is a little bit of itself is a sort of a premature designation, and I think a reflection of the overarching problem that we have a lot more to learn. So you know, I get it. There's ARIA-E and ARIA-H, and I get it that this is low end numbers and it is premature to make any sweeping conclusions. But I would take it seriously.
Could you touch upon that just for those of us that are not familiar with the terminology, what the H and E refer to?
Yeah, ARIA
Not hematoxylin.
ARIA is amyloid-related imaging abnormalities, obviously, and E stands for edema. So you do an MRI scan, you see edema, vasogenic edema, or Some people think it's, that's a little bit nuanced. And ARIA-H, H is for hemorrhage. So you give a person a drug, a certain percentage, fairly decent percentage, have MRI changes in their brain. Some have just edema, some have hemorrhage in addition to that. And in the clinical trials, of course, there's also the placebo group has a certain percentage of these changes as well, which is kind of interesting, but a little bit lower than the treatment group. So yeah, and I think one of the reasons why these cases got into our hands is the various emergency rooms out there don't live in the world of clinical trials in Alzheimer's disease. The patient comes in with aphasia and they're going to think it's a stroke. So I think as the medical community gets a little more educated on the issue, maybe some of these misadventures won't happen. But there is a push to get this out there on a very broad scale. And it's very hard to get autopsies on these cases.
Right. I have a question. Did I understand correctly that ARIA MRI changes can evolve over time and disappear?
Yes.
Do
Yes,
you have any thoughts on the mechanism for that? If what we're seeing is the destruction of vessels with the vasculitis, what do you envision is happening when those changes disappear?
I don't know. It's evanescent. I mean, it would be sort of speculation that there was some amount of vascular disease that resolved or healed or whatever, and the blood-brain barrier was a little bit more intact over time. But I think the majority of these cases, ARIA, people do fine as far as I can tell. The brain lights up and they might have symptoms, it might not. Very severe. There's some percentage, I think Dr. Perrin knows better than me, but some percentage are hospitalized. It's like 3 to 5% or something. It's an interesting area, but I could see if once the drug does its job and all the phagocytosis has taken place, and I can see it resolving potentially by MRI. I've worked with some radiologists who are very, very firm on the idea that resolution does not mean that destruction did not take place.
Thank you. We still have time for any more questions or comments. I see Dr. Hoffman.
Yeah, maybe I'll just ask another one. So these are obviously like the cases you've described are on the extreme end of the spectrum because most patients are not dying from these therapies and most do quite well. So do you have any clues from what is known about these patients in particular, since they all had pretty thorough workups probably in advance of being treated or during treatment, as to why they had fatal vasculitis and the vast majority of patients don't? Something about amount of amyloid at baseline or dose of medication or ApoE genotype or anything else like that?
I'm glad you brought that up, actually, because I neglected to mention our patient was a 4/4 homozygote, and so the patient was keenly interested in these therapies because of the genetic risk. Our patient also had an MRI scan 3 months prior to the open label extension phase, or during the process of qualifying for the open label extension phase, had no microbleeds. So there was nothing in our patient that would, other than the E4 risk, that would point. In other words, there was no evidence of pre-existing vascular injury / lobar microbleeds in our case. And that's why I emphasize at the outset that ApoE and imaging can only get you so far. There are going to be patients out there that have a lot of vascular amyloid and therefore a lot of antigen in their vasculature that are not going to come out on scans or ApoE genotype.
Thank you.
Are there
All right,
any
thank you.
additional questions? Oh, go ahead, Dr. Martinez.
I was gonna say, it looks like there are no additional questions, so Ashley, you can conclude the. Oh, sorry, now I'm seeing Dr. Perrin. Yes, that's right, although I'm not an expert. Many cases of ARIA-E are asymptomatic. Most of those that are symptomatic were solved both clinically and radiographically, though it can take some time for radiographic resolutions. And Dr.
Yeah.
Lee is asking if you looked at CD3.
We did very few. At least in our, n equals 1,
Yeah.
And I thought, I was impressed by the similarity with the other case from Vanderbilt. So very similar pathology in these cases, and the same time point, roughly from beginning to end of treatment.
All right. Well, thank you again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your PathLMS screen upon the conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you have completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again to Dr. Castellani for an excellent presentation. This concludes the session for today.
Thank you. Thanks for everyone for attending.